afternoon, everybody, and a really warm welcome to the second event in our Women in Psychedelics series. And this, of course, follows on from our hugely successful first event. In fact, this is the most watched event on the Drug Science YouTube channel. Fantastic. So I'm Jo Neal, Professor of Psychopharmacology at Manchester, and I'm chair of the Drug Science Medical Psychedelics Working Group. So I have that, that complete honour. Just to remind you that Drug Science is the UK's leading independent organisation providing evidence-based information about drugs. So the aims of the Medical Psychedelics Working Group are primarily education, destigmatization. So that event covers both of those. Research, and actually mainly, I should have said, enabling patients to access this much needed medicine on the NHS when that becomes possible, much like Drug Science is doing for medical cannabis with Project 2021. So folks, well done for coming. This is another extremely special event showcasing the fantastic and varied work of women working in psychedelic science. And we have enormous talent today. Hugely grateful to all our speakers for coming. One of the things we want to do is to redress the bias towards men in science. And we're doing this through our women-only series of events. So we really hope you'll enjoy today's session. As I see some of you have asked the question, it will be recorded. James Bunn, our Director of Communications at Drug Science, he is working really hard in the background, and it will go onto our YouTube channel this week. He asked me to remind you that you can leave this event and you can rejoin very easily using the same link that you joined with. Any link should work. Once you've joined, you will be able to hear the event, but if you keep your mic muted, that will make it much easier for us. And put your questions, please, in the Q&A panel. So as with the first event, we've got two parts to today's event. We have a panel Q&A for all the speakers of that session. So please get your questions ready. We always have a lot of really good questions, a lot of good discussion and debate at these events. The first half, again, as with the last event, will focus on clinical treatment. And we have two fantastic and very different projects we'll be discussing from Manchester and from Zurich. And we always like to include the patient perspective in our events. This is so important. And today we have a patient and a therapist in discussion with the chairperson in the first half. That is a very special part of this. The first half will be chaired by the amazing Meg Spriggs from Imperial. And you will remember that Meg spoke about her forthcoming anorexia trial with Psilocybin, which is coming up at Imperial in the spring. As before, the second half is focused on fieldwork. And we are especially delighted today to welcome two American experts. One will be focusing on gender balance in psychedelic studies, and the other on gathering data in the field, specifically in retreat settings with combat veterans. And we're also really excited to welcome an expert in the use of psychedelics by Indigenous people, specifically the Shipibo people in the Amazonian rainforest. This session is chaired by Drug Science's very own head of research, the amazing Anna Schlag. That's me done. I'm now going to hand over to Meg Spriggs, who's chairing the first session, and I'll see you again at the end for a quick sum up.
Thank you so much, Jo. Hello, everyone. Kia ora. It's amazing to be here again for the second Women in Psychedelics event. I have the absolute privilege of chairing this first session. So as Jo said, we're going to have two talks by researchers at Manchester and Zurich. And then I have the opportunity to have a Q&A session with a therapist and participant from the recent trial from Imperial College looking at psilocybin for depression. So I'm going to take the opportunity to ask my burning questions of these two, but if you have any burning questions, feel free to pop them in the Q&A, and I will try and get through as many of those questions as I can. At the end of this session, as Joe said, we'll have a panel with all four of our speakers, so I'll be asking any more questions that I have time to ask from the Q&A, so do feel free to pop your questions in there. So without any further delay, I will introduce our first speaker, Dr. Sara Tai. So Sara is a senior lecturer in clinical psychology at the University of Manchester and a consultant clinical psychologist for Greater Manchester Mental Health NHS Foundation Trust. So Sara is an experienced practitioner, trainer, and supervisor of psychological interventions for people experiencing serious problems that affect their mental health. Her research focuses on the development of psychological innovations and understanding of the mechanisms by which they work. She led the development of the psychological approach and therapeutic model for the Compass Pathways funded trial of psilocybin for depression, the largest trial of psychedelics for severe depression currently running. And get this, there are 216 patients across 21 sites in 10 countries across Europe and North America. She designed and ran the therapist training program and continues to provide ongoing support for therapists working in psychedelics. And I'm very excited to hear Sara talk about the importance of psychotherapy in psychedelic medicine trials. Thank you.
Thank you so much, Meg and Joe, and I'm delighted to be speaking at this event today, so thank you all for being here. I thought it might make it a little bit easier if I did have some slides so that you can just follow what I'm saying. And so I'm going to share my screen now, so I hope you can see those okay. Let me just get rid of that. Okay, so as Meg said, that I've been working with the Compass Pathways PLC on their trial, but I just want to make clear that the information that I'm giving today and what I'm talking about doesn't necessarily represent Compass's point of view, and you know, I am speaking from my own opinion, so I'm not representing Compass today. So let me just get started then. Thinking about psychological therapy and support, basically what we do know is that administering psilocybin with no psychological support is probably very physically safe, but it may well be psychologically unsafe. People often talk about what they call bad trips and things, and what we're aiming to do is to really reduce this, because we know that it might affect the potential for therapeutic benefit. Now, in most trials, when people are talking about the psychological support, they're talking about it occurring in 3 different phases. That's preparation, where we actually prepare somebody for the dosing session with psilocybin, the dosing session itself, and then the integration afterwards, which is all about helping them take meaning from their experiences and actually help make sense of that in their everyday lives. Now, to date, most of the trials that have been done have either done what we would call non-specific psychological support. So, for example, this is where there tends to be an emphasis on the role of psilocybin itself. So, for example, I'll give Robin Cartwright-Harris's trial in 2016 down in Imperial. I think they talked about their psychological support being one that wasn't necessarily aligned to a specific therapeutic model, and they described the therapist more as a supporter or a guide. Then there are also what we would call psychedelic assisted therapies, and these tend to be where there's a particular therapeutic modality. So, for example, it might be, cognitive behavior therapy, and it may be for a specific diagnosis. So you'd be providing that therapy, and psilocybin may be added in as an adjunct to whatever's being offered. So what happens in those therapies would be determined more by that unique therapeutic orientation. And I've given some examples here of those approaches. So there's CBT for smoking cessation, there's been motivational therapy, mindfulness, ACT, etc. Now, there are some potential limitations with both the non-specific and therapy-specific approaches. For the non-specific, there is a concern that it might give the message that it's all about the psilocybin itself, and it's the psilocybin which is really the main vehicle of change. Now, I personally have some concerns about that because I think there's a danger in us overplaying the very important role of neurological mechanisms, but underplaying some of the other mechanisms that we know to be important as well. So social, cognitive, emotional, and behavioral processes. And I'm sure anyone who's experienced difficulties involving depression and other diagnoses would admit that these problems are multifaceted. And therefore, what we really need are multifaceted approaches. And, we really want to make sure that we are thinking about things not just in terms of psilocybin being some magic bullet that's going to solve the problem, but it's an important component of what is a multifaceted approach, where there is as much emphasis on what's going on psychologically as what's happening, more neurologically as well. Now, I also mentioned therapy-specific approaches too. I think there's a slight issue with these two in that we know that most people who come for treatment or where treatments in the past haven't been successful for them, that comorbidity is a key issue. People don't just have one problem, they have multiple problems often. And we need approaches that are able to deal with many of the varied issues that are facing the people that we're working with. Also, most therapeutic approaches, so for example, a specific therapeutic approach like CBT or ACT, they don't necessarily provide empirical explanations as to what their specific mechanism of change is. This has been a common criticism of approaches across the board. And also, when we're training people in lots of different approaches, it does mean that it can be more hard to manualize these and also test the efficacy of these approaches. Also, many therapies have been criticized because they don't necessarily have unique contributions to what they do. They are often seen to be equal in outcome. They've been described as having what we call the dodo bird effect. And so really, we can't justify the cost of training people in lots of different disorders, in lots of different therapies. For psilocybin, it also poses future problems, potentially, because we would need to compare all of these different approaches in clinical trials. Now, as I said, if they do seem to have equal effects, I think it's more likely that there is some common ingredient across all of these different approaches, and perhaps we should be looking to focus on those. And that's certainly what I'm going to be arguing in the approach that I'm talking about today. So a key consideration that we have is we really need clear, empirically sound and evidence-based approaches to psilocybin therapy. It's absolutely essential if we're going to get this accepted into mainstream clinical practice. Good practice guidelines demand that we have clear theoretical principles, and I have to say there has been a bit of an issue with this in many of the studies to date. What are the clear theoretical principles that guide practice? And in order for us to improve practice, we need more details on this. We need a robust understanding of mental health per se, and we also need the ability to tease out what the effects of psilocybin might be from those non-specific therapeutic processes that are operating. So the theoretical approach to psilocybin that I've been working on is informed by a robust empirical framework, a theory called perceptual control theory. Now, I don't have time to go into lots of detail about that today, but the reason I have chosen this as the framework to inform the work that I've been doing, and that with Compass, is it's a biopsychosocial framework to understanding mental health. It's a functional model rather than a hypothetical model, so it's amenable to empirical testing. And it understands people in terms of the everyday functioning rather than being a model of pathology. And it explains human behavior and how people operate in terms of homeostatic principles. So it basically says that we keep essential biological, psychological, and social variables controlled within pre-specified limits. And I'll talk about this in a little bit more detail. So the main essence of the therapy is that people have unresolved and incompatible internal variables that they're trying to control. And this is what leads to distress. In order to resolve them, we need to have awareness of those internal variables. We need to be able to balance them in a coherent whole. So an example of what I mean by conflicting internal variables might be somebody who's experienced depression. They want to have a meaningful relationship with other people, but at the same time, they also have a standard of avoiding feelings of vulnerability. And therefore, they're flitting between the two and unable to control either to a degree that is meaningful for them and works. So in order to find a solution, people need to have awareness of both goals through increased attentional mobility, introspection, and problem solving. And that's really what we're trying to achieve in psilocybin therapy. Now, this fits with the general literature. You'll hear people like Kohler in the past, where they talked about insight learning with apes and things, how people suddenly develop new solutions. This fits with all of that previous psychological work. And also things like control and conflict are key transdiagnostic processes evidenced within the mental health literature. Now, introspective awareness has been seen to be so important in a whole range of therapies. So this approach really does draw on the key mechanism seen across the literature, and particularly in psilocybin therapy as well. Now, what we're doing in practice is helping people to focus on a problem at hand that may be, for example, relevant to their depression. And we're trying to help them downregulate the usual control strategies, such as rumination, that they may well use that block them from being able to develop awareness and solve the problem. And we often refer to these strategies as being involved in what's known as the default mode network, but I won't go into too much detail about this today. It requires them having a focus and a change in emotional state. So really what we're talking about is a process of exposure. And we're exposing them to emotions and experiences that they haven't been able to focus on before, and may be difficult in psychological therapy where psilocybin isn't used. We're trying to help them look at it from different perspectives to really evaluate it in different ways. Now, this is what preparation and the dosing session itself would aim to do. And then in integration, we would help them externally express this, because verbalizing problems and thinking about them from different perspectives is very different to doing it inside your own head. So this just gives you an idea of what the essence of the approach I'm talking about does. We do two main things: self-directed inquiry, which is about helping people direct attention to internal experiences so that they can expose themselves to a range of emotions, cognitions, and physical sensations, and also process those experiences in a way where they can evaluate it from different perspectives, as I just said. Those are the two key things to the therapy. And we use curious questions mostly to help people do this. The potential of psilocybin therapy is really important here. Many psychiatric drugs, like antidepressants, may actually serve to reduce awareness, whereas what I'm talking about is actually increasing awareness. Now, this might be really helpful for reducing the intensity of distressing emotions, but it could have the unintended side effect of making those problems longer term, because people are less able to evaluate them in the ways that we're talking about. Now, this really opens the door for psychedelic drugs, because it might be that they offer opportunities for increasing awareness, which is quite different. So it's a very different mechanism of change. So just to conclude, what I'm saying here, and I know this is very brief, I'm talking about a principles-based, theoretically driven approach, which builds on what we know to be useful across a whole number of psychotherapies and within psilocybin. We're really saying that people can develop their own capacity to direct their attention towards internal experiences, and the people we work with have the capacity to get themselves better and work out their own solutions rather than being taught or advised and being directed in a particular way. We're talking about awareness and being compatible standards and helping people find their own solutions for balancing the things that are particular to their own lives and their own important goals. And psilocybin, by its capacity to downregulate and make flexible usual cognitive and emotional and behavioral responses, may be a great way to help people develop new strategies and stop using some of the strategies that may have been counterproductive for them in the past. And that's me done, really. There's my email in case you want to ask me any questions. But thank you very much indeed. And let's see if I can stop sharing.
Thank you so much, Sara. I mean, I have so many questions for you now after that. I particularly like this idea of using curious questions. It's such an, I just like saying that, actually, curious questions. Okay, so next we have Katrin Preller joining us from Zurich. So Katrin received her MSc in neuropsychology and clinical psychology from the University of Constance in Germany. She then joined the University of Zurich, where she investigated the neurobiological long-term effects of cocaine, MDMA, and heroin use. After completing her PhD, she investigated the effects of psychedelics at the Neuropsychopharmacology and Brain Imaging Lab. She received an SNSF postdoc mobility fellowship and worked at the Wellcome Trust Center for Neuroimaging at UCL and at Yale University. Subsequently, she was appointed as group leader at the University of Zurich and holds a position as visiting assistant professor at Yale University. So I'll hand over to you, Katrin, now to talk about your research in psilocybin for alcohol use disorder.
Thank you so much, Meg. Thank you so much for the introduction, and it's such an honor to be here. I've also prepared some slides that I want to share with you, and I hope you can see my screen now. So I'm going to talk about our study. Oh, excuse me, now something seems to have gone wrong. Okay, can you still see my, oh.
Oh, we can see it now.
Okay, hang on. All good?
Yes, perfect.
Okay, now it seems like it's working now. Please interrupt me if something goes wrong again. So yeah, I'm so happy to be able to talk about a trial we're currently running at the University of Zurich, testing psilocybin in the treatment for alcohol use disorder. And I would like to start really briefly with a bit of background, because the whole idea of treating mental illnesses with psychedelics is obviously not new. There's a whole range of studies that were conducted when these substances were still legal in the 1950s and 60s. And about 20 years ago, or maybe even 30 years by now, the interest in these substances has risen again. But even these very early studies, and this is a meta-analysis that was conducted on the well-designed trials back in the 50s and 60s, they already showed that LSD, in this case, shows efficacy in the treatment in alcohol use disorder. And I think these are really interesting and promising results that motivated us to conduct the trials we're conducting now and revisit the idea of psychedelics in the treatment of substance use disorders, in particular alcohol use disorder. Now, these days, what we are currently doing is we're not using LSD for this trial, we're rather using psilocybin, which is very similar in terms of what exactly people are experiencing while they are under the influence of the substance. However, the duration of effects is quite a bit shorter. So with psilocybin, we're talking about acute effects of like so starting around half an hour, 1 hour, and lasting about 5 to 6 hours. And obviously that is there's a bit easier on the patient as well as on the therapist, where with LSD, we're talking about, well, 10, 12 hours of tripping, sometimes even longer, depending on dose and the metabolism of the patient. So there are quite some modern studies published already, and two in particular in the area of substance use disorders, one which is on chronic tobacco smoking and the other one on alcohol dependence. And I want to give you two really brief results out of these studies. And the first one is the study I was talking about on alcohol use disorder. And here what you can see is that the rate of alcohol intake, so the drinking, was reduced to a really very promising level after psilocybin had been administered. And the same holds true when we look at the studies looking at psilocybin for nicotine addiction. Again, 12, I think it was 12 out of 15 patients who stopped smoking altogether, and that is really impressive. However, these trials also do not answer all of our questions, and on top of that, they have some limitations that need to be addressed. And the first one is that the sample size is really small. So with the alcohol trial, we're talking about 10 participants. In the tobacco trial, we're talking about 15 participants. The other thing is they did not have a control condition, so no placebo control or anything similar. And as we had just heard in this really wonderful talk by Sara previously, the therapy that goes with the administration of the substance is terribly important. And well, probably, most certainly actually has an effect on its own as well. So we really need to control for these factors to figure out what the added value of administering a psychedelic really is in these trials. And the next thing, the next open question is that we really don't know what exactly the mechanism of action is. So why do these substances help the patients? And I kind of want to give you a bit of a list, really. I don't have the time to go into any details, but a brief list of things we think could be helpful, could be the mechanisms of action underlying the clinically beneficial effects. And the reason why I think it is really important to figure out what exactly it is that makes psychedelic assisted therapy clinically effective is because I think that figuring out the mechanism of action will actually help us to inform the therapy that we are conducting. So all the things that Sara introduced us to so nicely before, we will be able to develop a rationale of how we can deliver the best psychedelic assisted therapy possible by understanding its mechanism of action. So the list that I have put together here is, well, we could hypothesize that it is just a very basic molecular mechanism. So psilocybin might change the way the serotonin 2A receptor is expressed in the brain. But it could also mean, and we have evidence for that from animal studies, is that it induces neuroplasticity. And I think that possible mechanism is really interesting when we're thinking about therapy, because neuroplasticity alone is probably not going to be super beneficial on its own, but we have to guide the experience and the after experience into something that is helpful for the patient. And that will be the task that the therapy then has to accomplish. The other thing that I've worked a lot in the past is alterations in brain networks. So at least acutely, psilocybin changes the way that the brain is connected and that the brain processes information. And these alterations in processing information about oneself as well as the world could open up certain opportunities for therapy to be effective, to help the patient see themselves and the world in a new way. Also, we've seen that there is, at least acutely, something going on in terms of reward and emotion processing. Again, a very, very interesting mechanism, because we know that depressed patients in particular have changes in how they process the world. They process it in a very negative way. They have a negative bias, and potentially psychedelics could normalize this negativity bias. We've already talked a little about insight into dysfunctional behavior. Again, something that could be really important when we're treating patients who all suffer from dysfunctional behavior. And another thing that is very close to my heart and that I did a lot of research on is increased social connectedness. So we've seen in studies with healthy participants that people experience more empathy and that they feel more connected to the world, which would be a very important mechanism, because we know that especially psychiatric patients suffer a lot from isolation, from not being able to connect with their social environment. And also we have some evidence that this is one of the mechanisms that is also important when we are treating patients in our clinical trials, that this component of feeling connected with the world and their social environment is really helpful for the patients. Now, in the study I mentioned in the beginning, we won't be able to test all of these mechanistic hypotheses because you just can't answer all the questions you have within one trial usually, but we will be able to look into some of these mechanisms and try to find out whether they contribute to the clinical effects that we will hopefully see in the patients that we are treating with psilocybin. And to wrap this up, I want to give you a brief overview of how we are conducting the study in the alcohol addicted patients. So first of all, what we are trying to do is a little bit different from the studies the one study that has been published so far. We are using psilocybin in patients who have undergone withdrawal therapy. So in that moment where we are, when they enter the study and when they enter the psilocybin assisted therapy, they have undergone withdrawal. So they are not drinking acutely. But we also know that the worst thing or the difficult thing is not to get patients to not drink anymore. But we know that a lot of them manage to do that, but a lot of them also relapse. So we are trying to find out whether psilocybin can help the patients to stay sober for a longer amount of time. We are also conducting a randomized placebo-controlled design. As I mentioned before, the previous trials, they were feasibility trials, giving some really important insights into whether this could work or not. But now we are at a point where we need to conduct these according to methodological standards, which will show us whether the drug really is effective or not. And as I mentioned before, we're not only looking into efficacy, not only looking into whether that drug or the therapy that we are offering helps the patients, but we're also trying to find out why it is helping the patients. And this is how the study looks like. So we have 60 participants, 30 of them will receive psilocybin, 30 of them will receive placebo. All of them undergo a screening visit to make sure that they can enter the trial. We then do a baseline visit where we collect, where we get to know the patients, where we prepare them for the session, and where we collect all these mechanistic endpoints before they receive the therapy. After that, and these are the baseline visits, is actually, it's at least 2 visits before they receive psilocybin or placebo. So we can ensure that we have a trusting relationship with the patient and that they are well prepared for the substance administration. After that, as Sarah already mentioned, the integration work is really important. So people need to have the time and the context to be able to process whatever they experience during the acute substance session. And then we have a follow-up visit where we again collect these mechanistic endpoints and of course also look into the clinical endpoints. So really at 4 weeks after the treatment, we try to find out, well, did it work or did it not work? But 4 weeks obviously isn't enough. So also we do a long-term follow-up after 3 and 6 months, where we again ask patients how they are doing and if they started drinking again, and all the other clinical endpoints that we are interested in. And that's it from my side. Thank you so much for listening. And of course, I have to thank all the wonderful people that are involved in the study and who are running it and who are the therapists on these trials. And it's a really amazing team. I unfortunately cannot share any results at this point because it's still running, it's still blinded. But hopefully in about 1.5 years from now, I can come back and show you the results of this trial.
Thank you so much, Katrin. That's so exciting, and it's so wonderful to hear you speaking after Sara and speaking about sort of the therapy and the mechanisms. And I'm sure, well, I've already seen that there's so many good questions flooding in for both of you. So now we'll move to our next two speakers. So the next 10 minutes I'm going to be spending with Michelle Baker-Jones and Leonie Schneider to talk about their involvement in the Psilocybin for Depression trial from Imperial College. But just to briefly introduce them both. So Michelle Baker-Jones is an integrative psychotherapeutic counsellor in private practice based in London. She is also a member of Imperial College's psychedelic research team and was a lead guide on the Psilocybin for Depression study. She also offers individual psychedelic prep and integration for people who are struggling to process psychedelic experiences and co-facilitates a monthly psychedelic integration group with Richard Jones. Michelle is also co-facilitates a sharing circle with the clinical team of Synthesis. She will also be the lead therapist on an upcoming DMT trial, which will look at the potential of a longer infusion of DMT as a treatment for depression. And Leonie Schneider was a participant in the Psilocybin for Depression study at Imperial College in November 2019, and has experienced firsthand the transformative and life-enhancing effects of these medicines. To say her life was changed is an understatement, and Leonie is now committed to expanding access to these psychedelically assisted therapies and is retraining whilst deepening her own personal practice. Previously, Leonie hailed from a policy and research background in international development, focusing on connecting people via access to the internet and technology. Now she is focusing on connecting people to themselves, each other, and the planet through these medicines and therapies. While studying, Leonie is also working part-time at the as a psychedelic retreat coordinator for Alalaho. Did I say that correctly? Formerly the Psychedelic Society Experience Retreats. So I'm going to open with a question for you, Michelle. And if you wouldn't mind just providing us with a brief overview of the design of the trial and perhaps identifying the primary aims.
Mm-hmm. So basically the trial was a mechanism trial comparing psilocybin with a standard SRI. And so it was a randomized control trial, and half the participants would receive 2 high doses of psilocybin, and the others would receive a very low dose of psilocybin and escitalopram. So, and that the idea of the trial was to compare really which was more effective.
Amazing. So we had a psilocybin arm and a antidepressant arm. Is that right? Yeah. Thank you. And Leonie, how did you find out about the trial, and what led you to apply?
A couple of things. I've had a long-term interest in psychedelic medicines and how they've been used in indigenous cultures. So I've been long-term interested in this. I think what prompted me to apply was having read, as many people have, Michael Pollan's book, which really brought the whole field of psychedelic research and the trials that are underway into the public domain, mainstream conversation. And then a spot of Googling, because I really knew that if I kept on doing what I was doing, I was going to keep on getting the same results. And I was really looking for something different to shake up the snow globe, so to speak.
Yeah, I love that analogy of shaking the snow globe. So am I right in understanding that Michelle, you worked with Leonie as her guide? Do you want to tell us a little bit about what it's like guiding on a trial like this?
So yeah, so we initially meet the participant in the screening session, and that session is quite important because we're just establishing a rapport and seeing whether we feel, and obviously that has to be established quite quickly. So it's really about assessing whether we feel we can work well together, and getting to know a bit about their psychological history, and thinking, kind of giving some psychoeducation about what to expect on the experience, and sort of covering taboo subjects that might arise, and encouraging them to really, I suppose, adopt an attitude of curiosity and openness towards the experience. So it's kind of being brave, and so we wouldn't speak about a bad experience, but just challenging experiences. And quite often there's a sense that, whatever arises, it's about going in and through that. So that's very much the key concept of everything that arises is useful, and that really what we're doing as the guides is we're creating that safe space. So it's really whatever we can do to create that safe therapeutic container. And it's very much, this is the participant's experience. We're just there as say, like the cabin crew, just to make sure they have the safest journey possible. And if at any point, there's any turbulence, we'll be there to hold their hand. And often that's something we do very much on the ascent of the experience, just to help them physiologically feel safe and soothed. And then if at any point, they want to come out and talk to us, we allow that to happen, but we do then quite often encourage them to go back in, because, we feel that the medicine basically helps them to more than we can, and we make it clear that we'll have plenty of time and integration to discuss what's happened. And I think, that's something I remember Leonie a few times came out and, and then went back in and probably had deeper insights, especially on the descent of the experience, when you think, oh, it's kind of over. But I think, the more you go in, the more you get, the kind of richer your experience is. Mm-hmm. But yes, it's an honor really to be alongside people, to guide them. And it's not so much what we're just kind of creating the safety, but it's seeing them do that work for themselves.
Amazing. And Leonie, do you want to say a little bit about what it was like being a participant in the trial?
Yeah, absolutely. What was it like being a participant? I came to it with, I guess it's normal to expect some high hopes. Firstly, you're always hoping you're going to get the therapeutic dose and not be on the placebo arm of the trial. Even though your contribution is going to help science, there's that real hope that, can somebody else prove the theory? I really want the therapeutic treatment. Because I've had long-term low mood and period depression, and had reached a point where just taking a tablet every day was just numbing my experiences of life, really sort of narrow band of experience. And it was just getting weary, really. And I really needed to do something different. Otherwise I would be, it's that quote about madness is doing the same thing and expecting a different outcome. So I had no illusion that going in, that I wouldn't be coming out a completely different person. And I was. I think that safety Michelle speaks of is so important, because I knew that I could really go in deep and really go through any challenges that were coming up. Mm-hmm. And I was a bit surprised by the experience in that I didn't have what you read in the literature about ego dissolution. I didn't lose myself and become one with the cosmos. I was still very much me doing my thing, which is why I kept trying to convince Michelle that I was on the low dose the entire time. She had her reservations. It might have been something else. But I was convinced I was on the low dose because I didn't have that ego transcending experience. But what I did have is a very real and almost tangible embodied experience of my depression as a heavy coat, actually. That was the image that came out. It was something that was put on me, something that I've inherited, something that represents the patterns of behavior, the automatic responses, the defense mechanisms. And I think for me, the pinnacle of the trial was doing some of this deep work, realizing these layers upon layers that were suffocating and on top of me and not even really mine in some respect. And taking my mask off, looking Michelle in the eyes and saying, Michelle, I'm surprisingly unbroken. Putting it back on and going back in to carry on spelunking and exploring and trying to get every ounce of medicine I could out of this. And then obviously, that was just the start, a very intense day, but that was just the start. It certainly isn't replacing an SSRI daily with a psilocybin tablet 6 monthly. That was only the start. So, yeah.
Yeah, and I love I can feel, even through the computer, I can feel the trust between the two of you that must have developed throughout the trial. And those are some beautiful kind of images that you speak of there, Leonie. There have been a couple of questions in the chat for the both of you. Michelle, would you mind describing briefly what the setting is like in the trial?
So yes, it was a very clinical room that we had to transform into something a lot more ambient. So we had screens with lots of trees on. We had many salt lamps. Sadly, a few fake plants because we couldn't have real plants. And we would have, what else? We would have some art books. Sorry?
Fake candles?
Oh yeah, and fake candles, yeah. So lots of fake things, but I mean, I think it was very homely. We had, a soft brown blanket, I remember, and a few kind of what else? We had like wooden, I think maybe a shiva, and we had a very beautiful bowl that we put the psilocybin tablets in. So it was it was a bit of a sanctuary, I'd say, rather than very clinical.
Yeah. And do you have any more to add about what the setting was like for you, Leonie?
Having watched the first documentary about the Psychedelic 1 trial, which was very clinical, I'm surprised more people didn't have more challenging experiences in that setting. So I was so pleasantly surprised coming in and seeing something that is a dark windowless room in an academic hospital wing being transformed into exactly that, a sanctuary. As much as you can within that setting. So, and it just goes to show to what extent that is so important, the setting for a transformative experience.
Yeah, absolutely. And that actually leads quite nicely to another question that came up. And this is a question that I suppose often arises is across the trial, sort of these trials, how many times do you see quote unquote bad trips? So Michelle, I don't know if you want to speak to that a little bit.
Yeah, I mean, I suppose we would use the terminology a challenging experience, and often we very much prep people that you're trying to get to the roots of your depression here, and that there is learning, even in the pain. So it's very much, can you be with the pain? Can you go into the suffering? So often people do have cathartic or emotional breakthroughs, and that is through often a challenging experience. But again, it's about the meaning they make, what they take from it, and maybe like trauma. You've had something awful happen to you in the past, but there's this opportunity for a reparative experience because you have two hopefully lovely guides next to you who are alongside you, attuning to you if you're struggling, if you need support. So if you're going to face the dragon, then you've got your aides alongside you. So we just never really frame it as a bad trip. We just see it as something challenging from which you can learn. And I think the whole model around depression is that we're afraid of our pain, and it's very much learning to be able to sit with and express and feel our pain and I think that's the beginning of the process, the therapeutic process that starts to open up with the psychedelic session. And that's something we very much foster going forward. It's that capacity to sit with your pain and to grow and learn from it.
So beautifully answered, Michelle. And I'm just going to ask one more question of you, Leonie, before I open up, because we've got a bunch of questions for all of that. I think all of our panelists will be able to contribute to. I saw a question in the Q&A about sort of ongoing care, and maybe I don't know if you want to speak a little bit about what you've engaged in after, like how you've kind of taken forward the messages that you learned during the trial into your life and integrated that.
Yeah, absolutely. I think the trial didn't offer a lot of ongoing care because of the nature of the trial and the limitations to the study. But we had a remarkable opportunity to have, because of lockdown and Zoom, which came in just after the trial, to have some Zoom calls with Michelle and with Ros Watts. And I think for me, we started realizing the importance of group support, and not just therapeutic, but actually people who had had a shared experience, because of the fact that this is illegal largely and taboo in many respects. There are very few people that can really understand how you've gone to those places and what you've experienced. So part of my integrating has been speaking to others who've gone through the same process, and then supplementing a daily practice, really. A lot of time for meditation, reflection, body things has been something that's been really important post the trial. So really trying to get back into my body after being in my head for so long. Picking up yoga practices, stretching, mindfulness-based activities. And that's where the work is. It really is. It's, you know, over in 6 hours in the labs, but yeah, years of work.
Yeah. I often think of it as sort of psilocybin therapy opens a door, but you then have to walk through that door and you have to continue walking that path. So I'll invite our other speakers to join us on the panel now, because we've got a final sort of 10 minutes of this session, and there are so many great questions in the Q&A, and I'm going to try and get through as many as I can. So if we could just try and have brief answers so that we can get through as many questions as possible. But here's one for Sara. In terms of your point about psilocybin not being the causative mechanism of change in treatment, what are your views that psilocybin facilitates emotional breakthroughs or personal insights?
Thank you. Yes, no, it might be a case of my not having expressed myself very well there. I'm certainly not saying that it isn't part of the reason why people make breakthroughs. My point was about, you know, we shouldn't have psilocybin as this magic bullet where it explains all of the change. So I think people have already talked about the way in which it acts on the 5-HT2A receptors. And of course, that may have the effect of it really down-regulating the usual control strategies that we use that actually block us sometimes from being able to focus on the problem at hand and think about it in different ways and come up with solutions. So by doing that, you're really opening up the flexibility of somebody's thinking and emotions in order to make connections that they might not have been able to do otherwise. So I'm saying that psilocybin plays a really important role in doing that, but that's not the whole story. It's also about someone's ability to tolerate being exposed to those experiences in a way where they are able to make sense of it and think about it and generate new solutions. And that's as brief as I can be on that one. I hope that's enough.
That's perfect. Thank you so much. And one for you, Katrin. What is the placebo of your clinical trial? Do you have a placebo condition?
Yeah, so our placebo is real placebo, so it's really inactive placebo. There are various reasons for that, and I really don't have the time to go through all of them. So it's really hard to blind these studies, even with active placebo. So there are very few substances which would be able to blind an experience like that. And these substances that we might have at hand that might be able to do that have been shown to have antidepressant or anti-addictive potential as well. So they're really not good control conditions, at least at this stage of the work, right? So here we really try to go for a real placebo, inactive placebo condition to establish a kind of baseline. What are people experiencing if they're just getting the therapy without any additional substance on board? And that being said, if we have beneficial results of these studies and we move forward, then of course it makes a lot of sense to continue this work by comparing it to other active compounds.
Thank you. And we've got one here that I think both Michelle and Sara, you might both have a little input on this. An anonymous attendee has asked, would it be better that we keep the space to adapt our therapy model to the patient and their health benefits rather than trying to develop a best fit model? I don't know, Sara, do you want to start? And then Michelle, I don't know if you've got anything to add to that as well.
Yeah, I mean, I think we're on the same page here, that I agree a one size fits all is definitely not a good approach. But certainly when I was talking, the work that we've been doing over the years is about saying, what is it that seems to be common across all of these different models that enables us to focus on that, to create the optimum conditions for the people we're working with to try and help them make change. And I often use the analogy of a cast on your arm. If you've broken your arm, that cast does not repair the bone. It creates an environment in which the bone, repairs itself. And so we as therapists need to be as flexible as possible in order to create the best environment for that individual in order for them to help themselves. So I think I agree with what this person is saying in every way.
Yeah, so I suppose what we used or what we developed was Ros's ACE therapy model, which kind of grew out of Psychedelic 1. And in that it was non-directive to a degree, but it had the 3 processes of acceptance, connection, and embodiment. And it's using those processes flexibly and just as a way for people to think about, am I accepting my pain and suffering? Am I being with it? And it's kind of adapted a bit from ACT. And I think I've been looking recently at IFS, internal family systems, and I think the self-energy analogy and working with parts, I think, will also mesh quite well onto psychedelics. So for me, I don't think there is one model, but I think, hopefully with all this work that we're doing together, we can find out what works best. But I do think the idea of having processes that are ongoing, that you deepen, like acceptance, connection, and embodiment, and they were mechanisms that seem to grow from the work naturally. I do think that is quite a loose but a fitting model for psychedelic therapy so far, but we'll see, and I think it's worth exploring these other models too.
Yeah, I've recently got into reading about IFS as well. Really, really cool. So Leonie, here's one that you might be able to speak to a little bit. So someone has asked about when someone has a challenging experience, how do sitters navigate the session? And I wonder if in your experience, were there any challenging moments for you, and what was the best thing that Michelle could do and did do in that situation?
One of those strange situations, just knowing that Michelle was there was enough of a presence. Sometimes it's almost a protective factor. Her very existence at that point was sufficient. But when things did get a bit rocky, she mentioned the hand holding. I definitely held hands on the ascent, because there is some kind of fear and trepidation. So some kind of grounding practice. I know some participants that I've spoken to have felt a hand in the hollow on the back, hand on the shoulder. Some people might find some sense, a bit centering, something more grounding, earthy smelling maybe even. But for me, I think just sometimes I wonder if I missed an opportunity by not using Michelle enough during my time, in the sense that, but I think her being there was enough. And getting the benefit from that encounter was in the integration session. But I think it is a multi-sensory experience. The music for me was profound. I think also adapting the playlist depending on where the person is in their experience. The music is a real handrail guiding you up, and then descending on the other side. So, if the person's having a really tricky time, a different tempo to the music could help ground them.
Yeah, thank you so much. And we're basically at the end of our session here, but I want to just chuck one more question at all of you, and if someone wants to just put their hand up if they want to feel like answering it, because I think this is a really great question. So what are some specific areas within women's psychedelic research opinions that might differ from a male-dominated narrative? I don't know if anybody has anything they want to say about that. It's kind of a tough one.
I think women are probably more inclined to go along with the mystery of the unknown. I think that's more of a feminine, and being more embodied is more of a feminine principle. So those are 2 areas I think that may be more female than male, because I think, academia is very much about reducing the experience, whereas I think women inherently are more tolerant of unknown and not knowing. Not all, but
I love that. And I think that that's a really great way to kind of conclude this first session. So I'll just say thank you to all of you at this point now for being part of this event. I know that there are lots of questions in the Q&A that we didn't get to. We'll try and answer a few of them by typing, but please do keep your questions flowing for the second session. So I'm going to hand over to Anna now, who needs no introduction. She's a wonderful human, and over to you, Anna.
Thank you, Michelle. That was really great and super interesting session. I really liked the last question you asked, and we actually have our very first panelist presenter here in this session, who I think is actually an expert on that. And maybe we can even return to that. We start with Nicole Buchanan, who is a professor of psychology from Michigan State University, and the clinical director and founder of the Alliance of Psychological Associates. She's also an advisory committee member of the Chacruna Institute for Racial Equity and Access Committee, as well as a trainee for MAPS MDMA studies, if I understand correctly. And she very much hopes that the ketamine-assisted psychotherapy training and anticipates offering the psychotherapy when clinical trials with psychedelic-assisted psychotherapy are completed. So welcome, Nicole. We're looking forward to your presentation.
Thank you. Thank you for inviting me. I'm very excited to be able to talk today. I'm going to go ahead and share my screen so you can see my slides. How is that? Good? Okay, great. So, as a clinical community psychologist, I have been very vocal about the ways in which psychological science is going to need to change or risk becoming irrelevant to the masses. And if we look at how the field has functioned so far, it's failed to train clinicians in a way that allows them to be prepared for this rapidly diversifying population. And we see that this happens not only in who's currently trained, but also in the psychology workforce and who's coming through the pipeline. So we have a problem here where we have a population that's becoming ever more diverse, but we have clinicians that are not matching that diversity. And then when we look at those individuals that are doing psychological science research, that pool of individuals is even less diverse than the general psychology workforce. And the psychedelic renaissance has not truly extended itself to people of color or to the Black community in particular, which is the community that I represent. Black people continue to use psychedelics at a lower rate than do whites. And like much of the mental health field, psychedelic assisted therapy has failed to center the needs of people of color. Over 80% of participants in treatment trials are white, and less than 3% of them are Black. And across the globe, only 2 investigators for MDMA assisted psychotherapy studies are women of color, at least as far as I know. Trainees in the psychedelic assisted psychotherapy program still remain overwhelmingly white. And notably, it was only in August 2019 that MAPS welcomed its first cohort, and as far as I know, Asian and Indigenous trainees. As a result, this absence of people of color means that the protocols, procedures, and the training is often developed with little or no input from diverse scholars, and that participants of color do not have the benefit of having therapists and teams that are reflecting their cultural backgrounds. And as a consequence of the oversight, the consequences of these oversights are painfully articulated in the few writings by scholars of color about their experience in the field. And so what I want to talk today about is how do we go about increasing participation in psychedelic science? First, I want to acknowledge that the suggestions I'm offering today are not entirely novel and build off of the work of decades of scholars that have been discussing how to decolonize and diversify research generally, as well as Monica Williams and her colleagues' work on doing this specifically for psychedelic science. So one, we have to ask ourselves, who is doing the science? So as stated earlier, the scholars involved in the research are overwhelmingly white, including those that are offering therapy in clinical trials. And we cannot continue to have a science by and for white people if we want to be legitimate science that serves the world. The pictures I have on this particular screen, these are from the Williams et al. Article that I just showed you. And this is a picture of her research team. So representing a lot of diversity across visible and domains that are not visible from these pictures in order to make sure they're having input from a diverse group of people and that they are meeting the needs of diverse groups of people. And outside of simply diversifying the people, we need to deepen the knowledge of the concerns of people of color that they may be bringing to our research sessions. So during psychedelic assisted psychotherapy, clients are incredibly, incredibly vulnerable. They're stripped of their defenses, they're physically unable to leave during the sessions. And this ends up raising the standards for clinicians' cultural awareness and their competence in discussing sensitive concerns related to race, as well as their intersections with other key identities such as gender and sexuality. So with this in mind, for the very first requirement for psychedelic assisted psychotherapists needs to be a vigilant practice of intersectional cultural humility. We need to acknowledge that race-related contextual factors are important components of set and setting. And Williams and colleagues highlight a number of the themes that they experienced when they went through MDMA sessions that were specific to their experiences as Black women. And if you haven't seen that article, it's a wonderful article talking about them going through the trial and experiencing themes that were particular to them as Black women that the therapists did not know or understand how to discuss, or even experiencing microaggressions during the session that then limited the depth that they could go because their trust was broken. So the therapist's lack of understanding and engagement in these racist behaviors during treatment sessions actually highlights the urgent need to increase the number of therapists of color to provide these treatment trials as well. And we also have to think about what are we doing to actually attract these communities? What are we doing to let them know that it's happening? And what are we doing to actually invite them in if they do find out that we're doing this kind of work? And this is going to go beyond simply advertising about our studies. We need to be in the communities. We need to be talking and educating and creating relationships with the communities that we hope to bring in, because there's many valid reasons for them to be hesitant to come to us for these kinds of treatment trials. I also encourage people to review their advertising for their trials. Look at what are the themes that you're representing. Who are you highlighting in your advertising? So very often people will depend on the fact that people will want these treatments and come to them, but then that's how we only have 80% of participants, or we have over 80% of participants being white, because we're not thinking about who's missing. So as you can see on this advertisement, this is again from the Williams paper that I showed earlier, that not only is a person of color centered in their advertisement for their study, but they also include police imaging, because that is one of the common forms of trauma that people of color experience in the United States. So by highlighting not only the people, but relevant themes, it draws attention and it increases curiosity, and it is a marker that the people involved in the study understand something about my experiences. It's also important that even at the stage of the advertisement that you address safety at the onset. Again, there are many, many concerns in communities of color about what will it mean to participate in these kinds of trials, as well as the high level of policing and criminalization of drug use that happens in our communities. So we need to make sure that at the onset, we are addressing safety, because otherwise we won't even get people to the door to talk to us further. And I also encourage organizations to look at the setting they've created. You know, do they have diverse staff that are welcoming people, that are answering the calls? What is the art like in their offices? What's the music like? What are the reading materials that they have? And I encourage, again, an act of cultural humility to openly request feedback on how they're doing, and how they're doing specifically to meeting their needs as a person of color, as a queer person, as a woman. Directly asking that is not only a marker for openness and willingness to have the conversation, but it is acknowledging that these individuals are experts on their experiences and that there's always more we can learn to do better. And then we need to look at the protocols that we're using. And there's a lot of things I'm throwing out there. They're bigger than a 10-minute talk, but if we go back to the basic premise that the research protocols that we are doing now have been developed for and by white people, then the fact that other people have been missing means that there's obviously going to be content and problems in our protocols that need to be reassessed. So one of the things Monica Williams notes is that the intake and informed consent process needs to be a little bit different. It needs to go deeper into some of the concerns and fears that might be present in the community. It needs to address the risk and harms and the rumors about these kinds of medications in communities. They need to take longer and make sure that they are really giving people an opportunity to be informed as they participate in consent. And in doing this, that also tell others about it in order to create that support, or do they have some concerns and they don't want to talk about it with certain people in their community? Walking people through that, walking them through how to talk about it, and if at all possible, bringing in their community to participate and support them is really incredibly important. Oh, getting into time. And this is sometimes an unusual one, but we have to center social justice in this work, I believe. Psychedelic assisted psychotherapy is at this point standing at a crossroads, and it has the potential to be a therapeutic method that is going to center social justice and embody a healing justice. But we can continue down the road we're currently on, and we will perhaps offer that, but only offer that for a small proportion of the community. And to me, that is not enacting what these healing medicines demand of us. It is not reaching our full potential. The healing justice demands that we make healing a political act of resistance against oppression, and we conceptualize healing as a facet of social justice. And in doing that, we have to make the work of healing accessible for all people. So with that said, psychedelic science cannot live up to its potential without addressing systematic injustice that is inherent in its current enactment. By having primarily white researchers working with primarily white clients, this is robbing communities of color from the radical healing that these psychedelics promise. And we know that these medicines originated among communities of color, and then those same communities were then criminalized and denied access to these substances. So we cannot allow the healing that accompanies our modern psychedelic renaissance to continue to overlook their trauma and their right to healing. So if we are going to do this right, we need to engage in community outreach and education, acknowledging the valid reasons why people might be afraid, acknowledging the history and narratives that taught them that psychedelics were going to make them go crazy or burn their brains, the history of criminalization and police surveillance of people of color. This also means actively being engaged in decriminalization advocacy. We cannot be passive and then claim that we're interested in diversifying our field. And we need to engage in financial collaboration with Black, Indigenous, and people of color communities. We have to make sure that, given that these originated from those communities, that we are actively and intentionally giving back to these communities.
Thank you, Nicole. This was great. It was super interesting. And yeah, thank you for presenting. There are quite a few questions coming in already. And I look forward to discussing a bit more with my taking this offline as well at a different time, not today, obviously, because you raised so many important points, I think, that are often forgotten or still forgotten. And it's just so important that we start to really work in this direction as well. Right, I would staying a little bit on the topic, at least in terms of cultural humility as well, and appreciating traditional uses of these medicines. I would like to introduce Dr. Kate Pate. Dr. Kate Pate is a neurophysiologist, a lover of mountain sports, entrepreneur, addiction recovery and integration coach, as well as a yogi. She has a very broad scientific background, having spent over 15 years conducting research in a broad variety of fields. Within academic and industry settings, she is COO and founder of the Corona Medical, a military-specific medical research and product development company. And for the past 6 years, Kate's research has focused on military trauma medicine and mental health. And she herself comes from a military family, has always been passionate about helping military service members and veterans in whatever capacity she could. And this passion, coupled with her interest in plant-based medicines and her journey to find ways to heal from her own traumas, led her to cross paths with Heroic Hearts, and where Kate at the moment is the director of research, and looking forward to hearing more about it. Thank you, Kate. Welcome.
Thank you. I appreciate that introduction. It's a pleasure to be here alongside my esteemed female colleagues to have a discussion around some of these important topics and to share the research that we've been doing at Heroic Hearts Project with everyone. And I apologize, but I don't have any slides for you today. So for the next 10 minutes, you're just stuck with my face. As mentioned, I'm the director of research for Heroic Hearts Project, and I'm also a research partner for Unlimited Sciences, which is a psychedelic research nonprofit based here in Colorado in the States. And I won't be speaking about the work that we've been doing at Unlimited Sciences today, other than just to say that you may have heard about the ongoing psilocybin-focused research that we've been doing in partnership with Johns Hopkins University. That study is a prospective observational research study, and it's focused on better understanding how psilocybin in particular is being used in the real world. So by whom, how is it being used? How is it benefiting folks? Maybe how it's not benefiting folks, and ultimately what is happening in the real world setting. And it's very early into this multi-year study, but we expect the data to eventually help inform future clinical research and clinical practices. For those of you who are unfamiliar with Heroic Hearts Project, we're also a nonprofit, and although we do research, our primary intent at this point is to provide funding to veterans who are struggling with post-traumatic stress disorder and or any other treatment-resistant mental health issue to attend ayahuasca-based healing retreats. We're passionate about the work we do because we're determined to provide alternative approaches to those that are currently offered by the VA, which at this point primarily consist of medication and psychotherapy. And it's not uncommon to hear about veterans walking out of the VA with a daily prescription of something like 10 to 20 pills, each addressing a single symptom or counteracting the negative side effects of other medications that they've been put on. And after everything these guys and gals have done and gone through while serving in the military, I feel like we've let them down in how we've tried to take care of them on the back end once they've returned home. So at Heroic Hearts Project, we're really trying to provide an alternative option to the traditional and somewhat backwards, in my own words, backwards healthcare model. And our organization has engaged in research for a few reasons. First, we want to understand as much as we can regarding which veterans might best benefit from this approach to healing. And we want to understand how it's benefiting individuals. So what are the specific improvements that folks are experiencing in their overall mental, physical, and spiritual health? And perhaps starting to understand maybe some mechanisms by which these benefits are conferred. We do recognize that ayahuasca and other plant medicines may not be beneficial for everyone, at least where they're at in life today. And we want to understand that too. So which individuals may not benefit from this approach to healing. Ultimately, our goal there is to better inform our community of veterans and help give them more information to make better informed choices for themselves. We're not the gatekeepers of the medicine, nor do we ever want to be. We really just want to arm people with information and let them exercise the autonomy that they have to choose what to pursue with regard to whatever healing path is right for them. We also do research because veterans are a highly educated population and quite skeptical of information without any kind of research or data to back it up. So providing information with research to support it is really incredibly important for letting people in this community know what might be available for them. If there isn't data or research to back it up, a lot of people will immediately just discount it as something that is a viable option for them. And in order to I guess, provide more information for folks and get people to understand the benefits for some plant medicines, especially ayahuasca, we really need to destigmatize mental health issues and the use of plant medicines for healing in the veteran community as well as the global community. And we feel like research is definitely one way to do that. Finally, we do research because we're starting to recognize that a lot of veterans don't fit under some of the traditional mental health diagnoses, such as PTSD per se. In fact, many with PTSD-like symptoms don't ever report feeling traumatized or feel fearful or avoidant during combat, and actually loved being in the action. So there may be some other underlying root causes for their symptoms beyond psychological trauma, such as traumatic brain injury or even toxic exposures on deployment or during training. So although it's not an official diagnosis at this point, there is a term called operator syndrome, which has been coined to refer to the complex and far-reaching cluster of symptoms that many in the special operations community experience during and after service. We at Heroic Hearts Project recognize that effectively addressing novel health issues and symptom clusters like operator syndrome may require novel ways of thinking and problem solving. So to that end, we're currently focusing our organization's research on understanding how ayahuasca is benefiting veterans who are struggling with mental health issues, but also how it's impacting the gut microbiome in these individuals, and how those changes in the gut microbiome may be correlated with long-term psychological and behavioral outcomes in these veterans. So that gut microbiome mention may sound like it's out of left field. So why do we care about it, and why are we studying it in this context? Our interest lies in the growing understanding of the bidirectional relationship between the gut and the brain. It's been established that the microbiome gut-brain axis plays a significant role in both physical and mental health, particularly as it relates to inflammation. And inflammation in the gut can influence inflammation in the brain and vice versa. For any of you out there who have sustained a head injury and subsequently experienced any kind of GI issue or GI distress, you probably and unfortunately know this to be true. It's also well established that various types of stressors can alter the gut microbiome in ways that permit opportunistic pathogens to flourish. The wrong combination of microorganisms in the gut can lead to a breakdown of the tight junctions between the intestinal epithelial cells and the mucosal lining, allowing bacteria to move through the gut and into the body, ultimately causing a systemic inflammatory response. Inflammation prior to or at the onset of a traumatic or highly stressful event can increase a person's risk for developing PTSD symptoms. So targeting inflammation may be a rational strategy for the prevention and the treatment of PTSD and other mental health issues such as depression and anxiety, which have been correlated with neuroinflammation. One way to potentially address the gut microbiome and improve the gut microbiome's diversity and promote a healthy profile is through dietary approaches. And those dietary approaches may improve stress resilience. So enter ayahuasca and other psychedelics with an oral route of administration. These medicines will pass through the gut, and we know how sensitive the composition of the gut microbiome is to what it comes into contact with. So it remains to be explored, but we hypothesize that ayahuasca's many bioactive substances, including the various alkaloids present in the ayahuasca vine, could promote a shift in composition in the gut microbiome in a way that favors anti-inflammation, an effect that could be transferred to the brain via that microbiome gut-brain axis, ultimately promoting improvements in mental health. Conversely, it's been postulated that the classic serotonergic psychedelics may be somewhat anti-inflammatory in and of themselves. So there may be a reverse mechanism at play as well from the brain back to the gut. So our team is exploring this currently, and we have a group of 25 veterans that we've collected data on at this point, consisting of personality variables, including 5-factor model traits of neuroticism, openness, agreeableness, conscientiousness, and extroversion, along with psychological flexibility. And we've also collected mental health information, including assessments for PTSD, depression, and quality of life. We also have other self-reported variables that we've collected, including positive and negative emotions, and physical activity, social activity, sleep, and of course, something highly relevant for gut microbiome studies is the participants' diet. They've kept food logs prior to retreat and during the retreat. Major self-reported measures were collected 2 weeks prior to attending a retreat, an ayahuasca-based healing retreat. Within 2 days after their last ceremony, because most of the time these retreats would be multi-ceremony retreats over the course of about a week. And then we'd follow up 3 months after returning home. We also have pre and post-retreat stool samples for the gut microbiome analysis, and these were obtained on site. So when participants arrived immediately before their first ceremony and before they left after their last ceremony, these retreats the settings were in Costa Rica and Peru. And we're currently in the process of analyzing these data in partnership with Dr. Chris Lowry at the University of Colorado in Boulder, who's doing the microbiome analysis, and Dr. Keith Campbell at the University of Georgia, whose team is doing the psychological and behavioral analyses. We were planning on having a much larger number of samples by now, but of course, due to travel restrictions this past year, we were unfortunately limited. So we have 25 samples, and that's where we're at today. But we hope to continue to add to that over time as we're able to send more folks on retreat. And we do recognize that there are a lot of limitations to observational research of this kind, especially with regard to the gut microbiome, which is very sensitive to things like changes in diet and travel, both of which are involved in attending these retreats and participating in the dieta prior to these ayahuasca ceremonies. But research in new areas has to start somewhere, and pilot data coming out of this project will hopefully inform the direction for future research, not only for our organization, but for others as well. And that's all I have for you today. I hope to share with you soon some of our data as we get through these analyses, but that's something to look forward to. So I think that's the end of my time. Thank you all for listening. And if anybody wants to reach out, I will drop my contact info in the group chat.
Thank you, Kate. That was absolutely amazing. I would urge you, as well as all the other panelists, to also have a look at the group chat. Really nice comments to all of you and really interesting points really raised. Thank you for presenting all the science, basically, and so much exciting work coming. And I'm really looking forward to actually seeing and hearing more about the results. So before we get to questions and to the Q&A, and staying on the topic of ayahuasca, we have Sophia Vassiliou as our third speaker. Sophia is the founder of Ayahuasca What Now? Sophia is dedicated to help people fully integrate their medicine experiences and to bring the lessons, transformations, and teaching of the plants into their grounded everyday life. After spending nearly 3 years in the Peruvian Amazon with the Shipibo and facilitating retreats at the Ayahuasca Foundation, Sophia believes that the biggest transformations occur not in the jungle or ceremony space, but back home in everyday life when trying to put the new ways of being into practice. Sophia was born in the UK and has an honours degree in ancient history and has traveled all over the world, working as a therapist in many alternative modalities, which reflect her love of bringing ancient wisdom teachings to the modern world. So welcome, Sophia. The floor is yours.
Hi, thank you so much. So I guess a little bit about my background. I practice as a holistic therapist, and I've been doing this for many years now. And the way I came to ayahuasca was at a point of extreme depression and not knowing what to do or who I was in my life. And I did a ceremony in the UK, a series of ceremonies, in fact, over a weekend of 3, which often happens. And it was great, but it also felt like it was missing something really essential, which was the ceremonial Indigenous touch and the authenticity of being guided by a curandero. And so I did that in the August, and by the following January, I was in Peru doing an immersive 6-week retreat at the Ayahuasca Foundation in Iquitos. And then I understood more about ayahuasca. So one thing I would really like to highlight in this talk is that especially with the Shipibo, who are often considered as the masters of ayahuasca. You know, ayahuasca is used across the Amazonian basin for many reasons, some celebratory and to connect with spirit, and some more medicinal, and all are extremely valid. My speciality is with the Shipibo because that's who I trained with. And they really see ayahuasca as just a very small part of an entire medicinal paradigm. And this is really important because often I find that in the West, as the wonderment of psychedelics is being used for the for this kind of psychological benefit, we are forgetting a lot of the other things that this whole paradigm is used for. And so the Shipibo use ayahuasca more as a diagnostic tool, and then use the rest of the jungle as the actual medicine. And I feel this is really fundamental because part of bringing ayahuasca into the West is doing it ethically and without losing its essence. And I've seen some questions in the chat about using practitioners who are initiated, and there's many important things to think about when we do use these indigenous tools for our own benefit. The maestro who I trained with, he believes it's his divine mission to spread this knowledge to the West. And it's actually, he designed a course with an American, Carlos Tanner, who they came together to create this idea where they would teach ceremony, they would teach dieta, they would teach about different plants from the jungle and spread it throughout the world in a way that is honoring the culture. And so this is sort of an answer to the idea of cultural appropriation, where it's assumed that we're taking from the indigenous. And obviously there needs to be a lot of care and concern about that, but there are some indigenous people who really believe that this medicine needs to be given to the world because the world really needs it right now. And I believe that this is part of why ayahuasca and the psychedelic renaissance is happening, because we're in such a psychological pickle, as it were. So some of the other things that the Shipibo do, which really talk to some of the things that came up in the last talk actually, is stomach cleanses. Straight after the first ceremony at 6 o'clock the next morning, we would actually do a purgative to clean the stomach lining. And we would do a series of several purgatives throughout the experience, detoxifying different parts of the system so that the medicines could enter more easily. And yes, the idea of the gut microbiome interacting with the brain in terms of physiological and emotional health, I think is really interesting that that's being researched. Another thing that's really important with the indigenous use of ayahuasca is the idea of spirit, or spirits, more to the point. So with the Shipibo, they do dietas, which is the curandero's way of creating allies in the spirit realm. And they use ayahuasca as a gateway into a completely other realm in which other beings give them information. And so creating these relationships with different plants who exist in that realm and physically in our realm, they have allies in this place. And so they get given information about the root cause of the illness, the root cause of the psychological issue that the person is dealing with. And then they also get given the remedies, and they get told the different means of curing this person. And so it's a much grander holistic approach to working with a particular issue. I also find that in clinical trials using synthetic psychedelics, this issue doesn't come up as much. And I'm wondering whether it's because of the organic nature of ayahuasca and magic mushrooms rather than synthesized psilocybin, or using peyote, because this idea of spirit and the spirit realm seems to come in more with the organics rather than the synthetics. And yet it doesn't mean that participants can't have a spiritual experience with the with these synthetics. There's quite a distinction between the spirits, as in the spirits of the plants as distinct entities, and the spiritual, as in that divine connection, which we can feel where we're connected to everything, which is an extremely common psychedelic experience across possibly all substances that have been used in these kind of trials. So in terms of how we can respectfully bring this into our cultural experience in the West, it's been really delightful to listen to all these different speakers today, actually, to hear about the care in terms of preparation and integration, because that's absolutely necessary in this field. Sending someone to the Amazon is quite hectic. You know, it's a completely radical shift of every sense of familiarity, and just dumping someone somewhere completely alien, people singing in foreign in the pitch black, vomiting in buckets, you know, it can be very, very jarring. And if you're not prepared for that kind of experience, or you don't have guides there who are sensitive to the Western psychological framework of trauma, the kind of things that can come up for us as we're processing our emotions, it can be really dangerous. And so I love this idea of fusing the ancient technology with a Western framework of psychology when we're using ayahuasca and these medicines in this particular way. In terms of advice, it would be around continuing to build these bridges and giving platforms and spaces for people to be able to use the best of both worlds, really. But also make sure that we don't become the sorcerer's apprentice, you know, especially with things like ayahuasca, peyote, and other cacti. These are ancient technologies which have a really specific function, and that fact that we are entering another realm that has been understood by the indigenous for potentially millennia, to assume that we can just take part of that and dump it into another framework and use it safely can have a little bit of hubris attached to it. And so it's about creating a dialogue with the indigenous and allowing facilitators and even cultural leaders to come over and facilitate these ceremonies when using those particular plants with the people like who have just been talking, also being able to hold the space for the Western participants who need that psychological understanding, need that hand-holding, need that support. And in that way, we can get the best possible results in terms of physical, mental, emotional, and spiritual healing for everyone who wishes to do it in that particular way. So we can really recognize the strengths of each of these paradigms and also the blind spots. Because, you know, there's some things that we just aren't aware of. As the Shipibo also are very quick to label a particular symptom as X. And, you know, it's not always the case. And so just using both and really learning from each other is what I really enjoy. I can't really emphasize enough this preparation and integration side of things, where we really allow people to understand what they're getting into, which you never can really be prepared, but there are certain things you can do to bring the experience into a much more safer territory. Like Leonie was saying, that having a grounding practice that she understood beforehand, where she could actually just learn to center herself during the experience, super useful and really, really appropriate. And then the integration on the other side, weekly support to just process every now and again, just to relive and understand what's happened. And as your understanding of the experience shifts over time, not thinking, oh my gosh, everything I thought that was true when I came out of it is completely wrong now. Actually, no, as we develop as people, we see things from a different perspective. And so just allowing that unfoldment. So, you know, for some people, it will be the best option to go to the jungle and go indigenous and do it in the authentic setting with the jungle plants all around and the noise and the foreignness. And for other people, that's absolutely inaccessible and inappropriate. It would be quite traumatic. It would possibly be life-threatening, depending on their ability. And so, you know, let's learn how to bring the jungle here as well, because I think these should be able to be accessed by everyone who needs them. So the key things to remember is who's serving you, what are they serving you in terms of which medicine, when is appropriate for you, where you're going to do it, and why you're doing it in the first place, and choose wisely.
Thank you, Sophia. That was a really different perspective and absolutely valuable in terms of the discussion that we have and that we're hopefully continuing to have. I like the way you brought forward the kind of your knowledge of the Indigenous traditions, as well as connecting it with some of the work going on in the West at the moment. I have met Carlos as well, and I know his approach. And one thing before I get to the audience's question, referring back to Nicole's talk specifically, really in terms of making these type of medicines more accessible to the general population. I'm not necessarily mean ethnic minorities, but also maybe different socioeconomic status. I mean, many people cannot just travel to the jungle, even if they want to. You know, I think we do have to keep that in mind, and the importance of making the medicines accessible for different groups of people and different segments of society, if there's a need for. Right, I'd like to go to some of the Q&As. I have here, hopefully for, let me just double check, where are we? There's a question for Kate, a very specific one, so I'm just going to ask you quickly. From Paul Klein from Anglia Ruskin University, are you finding PTSD and operator syndrome in drone operators?
Yeah, that's a really good question. You know, honestly, I haven't done enough in that specific area with drone operators per se, so I don't know how the operator syndrome appears if we were to stratify that according to particular specialty or MOS or job description, how that might show up. I would suspect that it would probably be more prevalent in those who are exposed to higher blasts and higher incidences of head trauma. So those who are kind of more you know, used to breaching and near high explosives, EOD techs. You know, I think that there are certain professions within the special operations community or conventional forces at large where there's going to be risk factors that are predisposing someone maybe to going down that path. So I think those who are exposed to more types of head trauma, even at low levels, like subthreshold concussions that are just from blasts related to heavy weaponry, that can accumulate over time. So I don't know about drone operators in particular, but I think that that's something that we would certainly want to start exploring by stratifying according to job description. So thanks for pointing that out.
I'm just sticking with you, Kate, for another specific question. Do you have any studies done on the effects of purging regarding the gut microbes?
That's a really good question too. And you know, from everything that I have understood regarding purging as well as diarrhea with that, you know, accompanies the consumption of ayahuasca, this hasn't been extensively researched at this point, but from the shamanic perspective of those who are administering the medicine, according to them, those are processes that actually are kind of a reset for the gut microbiome. So it's not for the gut in general, for gut health in general. So folks who have consumed ayahuasca, although the acute effects are somewhat GI distressing, over time, it actually leads to improvements in GI health for many folks. So there's something going on with the consumption of ayahuasca, and whether that's separate from the purging and the diarrhea that may accompany that, or if it's all kind of rolled in together, it seems to, from anecdotal reports, it seems to kind of have a gut reset. And maybe that does clear out the microbiome in some ways, but maybe that's not a bad thing if folks have a tendency towards maybe a more inflammatory gut microbiome profile. So a reset could be a very good thing for folks who are in that place, which, you know, many people I would err on the side of caution, but I would just say that probably more people are a little bit imbalanced in the pro-inflammatory side of things than they are in the anti-inflammatory side of things. So that's just my 2 cents on that. But it's a great question, and I would love to dive into the literature. I'm sure there's some information that I'm unaware of that's been published on that, but that's all I can contribute to that question.
Thank you, Kate. So this is for Sophia. Are you particularly worried, or where are you worried about psychedelics that stem from ancient traditions being abused by Western society?
Yes, that definitely is a concern of mine. And it goes back to what I was talking about, this understanding of the spirit realm, which I feel that the organic psychedelic medicines have been sort of are an entryway into. And it's very easy for a ceremony to go right, but it's also very easy for a ceremony to go wrong. And with the energies that can come into this space, you know, we always had a saying like, it's okay until it's not. And I find that if people haven't been trained in understanding that and aren't able to see what's happening from that perspective in the ceremony space, it can get pretty dicey. And so I always feel that there needs to be a genuine connection to a lineage if you're working with Western practitioners, and those questions should always be asked if you're looking for ceremonies.
Again, staying with Sophia, how different was doing ayahuasca in England to doing it in the traditional context in the jungle, and how would you compare this? It's basically also a question, I think, for people who maybe for whichever reason cannot just go to the jungle. You know, is it as worthwhile? What's the difference?
I mean, it would completely depend on who you drink with. I mean, one thing is the noise. Just having the jungle in the background, having that orchestra of just nature around you is just something that's indescribable when you're going through that. The Shipibos also do their ceremony in pitch black. And so unless the moon's shining, you're in complete darkness in a room on your own. And there's not necessarily anyone unless you say help, and there's no light. So that's not the case for all Indigenous settings. But in Western ceremonies, there tend to be candles somewhere in the space so people can navigate a bit more easily. And also the music and there's no instruments. It's just pure a cappella singing in the jungle. Whereas we tend to put on ambient music, and there's some Ikaros and some other voices. So it's just completely different in many respects. And the other thing is that dissociation from the other medicines that you take, the other things like the saunas and the vapors that you inhale during the day, and the many things that create the healing experience in a jungle setting, just absent in something that's really focused on your personal development rather than healing as a total.
Yeah, it's a complete practice, isn't it? Yeah. And just going, I think, to wrap up, I would love to have a quick question for Nicole, if you're still here, Nicole.
Yes.
And really, I mean, I loved your talk, and there was so much detail in it. Like I said, we'd love to have you back in a different capacity, I think. But what would you say are the key points for improving the current situation in the access? I think quite a few of the points you raised, these are longitudinal points. This is not going to happen overnight. But where do we start? I mean, we have started, I shall hope, but how can we move along fast, especially as a white middle class researcher? Yeah, what is the best thing we can do? If you can give us just a
and I missed the very beginning. You're saying to increase access more broadly?
Well, to increase access for BAME communities in the research as well as participants, like what you talked about. What are the key takeaway things? What you would suggest? What would you like to see?
Well, I can speak from the perspective of what's happening kind of in my local community. There's nothing happening here in Michigan in the United States. There's nothing happening in my immediate district. And I have several things prepared in order to be able to participate in expanded access. Then COVID hit. But even having opportunities for additional loans to rehab the building or to acquire a building that meets all the requirements would make it so that our clinic could be starting this with all of the appropriate protocols in place and with all of these recommended suggestions, because we have 90% of that. And then also, if some of these major training institutions offered opportunities for helping individuals make the connections with the medical personnel and the other professionals that need to be in place. So almost a consulting model around getting these centers up and running, I think would open up many more opportunities for people who are not connected in this already to offer this, to offer these types of training protocols, and then to participate in them as research protocols. So I think there's the lack of information that has typically happened within these communities also extends to the scholars and to the therapists that want to be able to offer this work. And so creating a pathway for individuals to find out more of the practical end of it, and to perhaps have mechanisms for getting the assistance to build capacity to do that, I think would be one way that, you know, when I think about our cohort of 40 people, many of them are facing logistical challenges that they need consultation on. And that would be one way to do that. I think we could also have a much more active advertising and outreach campaign that's happening through larger organizations as well as individuals doing this work, so that people begin to see the faces of the people that are doing this kind of research, and they're able to connect with stories of healing that have happened. So as we have more people going through the protocols, as we have more people participating in these studies or who have done this through ceremony, of course, this also means that decriminalization has to have happened, right? For people to talk openly and honestly about their experiences. But as we can get more information to communities about ridding ourselves of the myths that often have plagued our communities about what some of these medicines will do to you. In my upbringing, there was the story of Lonnie who came back from the war, and he took something, he dropped acid, and for the rest of his life, he was permanently impaired. We need to have active community-based campaigning that teaches new narratives around what these do for those communities that have those kind of narratives. So helping the infrastructure around the therapists and the scholars that want to do this work, and helping with community education and outreach so that people have honest and valid stories about how helpful they can be. And we have to work on decriminalizing, because as long as the risk is disproportionately on our communities, people are going to stay away, and for good reasons.
Absolutely. Thank you so much, Nicole. And I think that, this is absolutely important. I think just to highlight that it's part of a much broader picture in terms of drug policy. I love Professor Carl Hart from Columbia University, who's doing so much amazing work for the broader area. And hopefully we can continue that here in the psychedelic space. I would like to thank all the participants or the presenters for joining us, and pass back to Professor Jo Neal, who is just going to sum up and have some concluding remarks. Thank you, everyone.
Wow. Stunned into silence, which doesn't happen very often with me. Thank you very much, Anna. What a brilliant afternoon. And I see one of the delegates has said loads to think about. And what I'm seeing in the chat is massive thanks from so many people. So many questions, and something I want to say a big thank you to the speakers for answering nearly all the questions. That's a great facility here, I think. Absolutely, this afternoon has just flown. We've had 240 people here at the peak. What a fantastic afternoon, everybody. Thank you so much. So a massive thank you to all our speakers. I know you're all incredibly busy. You've joined us from the States, from Zurich, from all over. The chairs, keeping everyone to time, absolutely, because so many questions. It's a really tough job chairing this. And thank you to you, the audience, for coming. Made this such an interesting discussion. And there's so much to talk about. I think we could go on a lot longer. I have learned absolutely loads. So huge thank you to everybody.